Hello, moms and dads. A very warm welcome to this episode of Today's Parent. I'm your host, Christine Kasina. Are you guys pregnant? Congratulations. In today's episode, we are going to talk about labor complications. It's one of the things as parents-to-be, we never want to imagine that anything wrong could happen. But complications do happen. And to help us understand more, we have a gynecologist who is back, popular with moms and dads. Her name is Dr. Kakuti, who's going to share with us different types of labor complications. Dr.
Thank you, Christine.
Welcome back.
Asante sana.
It is awesome to have you.
What a pleasure.
I'll start off with my first question, and my first question is, when it comes to labor complications, who is at risk?
So the risk would either be from the baby or from the mom. So if I start with the mother, a long time ago, if a lady was short, less than 5 feet, wore shoe size 3 and 4, they were considered to be a very short woman.
I'm looking at my shoe size right now.
So short stature women, I think when I was in Kenyatta, they were almost taken for cesarean section.
Automatically?
Almost automatic. That if you did not, that it was assumed that your feet are so small, so your hip size, remember the pelvic girdle is where the baby is going to pass through. So the baby's head is a bone, the pelvis is a bone, and they have to negotiate each other during labor to pass through. And even the baby's head molds itself. So it was assumed if a woman is short, has small feet, size 3 and 4,
It places her at risk.
that puts her at risk of having an obstructed labor or a poor progressive type of labor. The other thing you have is a malpositioned baby. Now, when you want when you do a scan to tell the position of the baby, now position and presentation are different. So position is whereby when the baby is born, the baby should come out and face downwards. But occasionally you'll find a baby whose head is facing the other way around. So when the mother is lying flat on the bed, this part of the head is supposed to be facing forward, but sometimes it faces backwards. So we call that occipital-posterior position.
Right.
So the diameter that enters the pelvis is larger, and there's a risk of poor progressive labor. Not obstructed is when you've taken the labor too far. The other risk is a baby who is not moving very well and not very active, which is not very common. Or maybe the mother has fibroids, so the baby has what is called breech presentation. So breech is whereby the head is up. So either the buttock of the baby is presented, so that we call that an extended breech, meaning the baby's knees are extended to the face. So when you do an examination, you feel a buttock. You feel something very soft compared to when you examine the mother and feel a bone. Or you feel the feet. Sometimes a mother goes into labor and boom, the first thing you're seeing is a foot, and you're like, this is
I wonder just how you try not to react and go, oh.
We always go, oh. We're always like, oh, this mother is for cesarean section, unless the breech is advanced. So the other complication you may have is mothers who may have certain complications in pregnancy or medical conditions like diabetes.
Like prior health issues.
Yes, prior health issues. So especially diabetic mothers. So what happens is the pathophysiology in diabetes in pregnancy deposits fat in the baby's shoulders, and the babies tend to be bigger. So what happens is a bigger baby, even with a mother who has a normal sized pelvis, that baby is not going to pass through. Genetically big babies, you look at a dad, the father is 6'5", the mother also is 6'1", then there's a possibility. But then we expect that the mother's pelvis may actually coincide with the size of the baby, and the baby can pass through. The other complication now with the mother would be, apart from diabetes, with if she has fibroids. So
so that's a risk factor as well.
That's a risk factor for malpresentation of the baby. Fibroids, majority of the time, do not cause any issues during labor and during pregnancy, but they may cause issues with they're competing for space with the baby in the uterus. So if you have a big uterus, in the inside of the uterus, a submucosal, what we call submucosal fibroid, then the baby may not be able to turn
to get enough space to turn.
Exactly, because the baby most of the time is in, the baby is inside there, can be in any position. But by the time the mother gets to 36 weeks and towards labor, we want that head to come down. So those are some of the risks you get with that can give you complicated labor.
All right, Dr. I wonder, in this age and time where, sometimes it can become difficult to be active, and we become a bit big, especially when we are pregnant. Is weight an issue? A risk factor when we are, I don't know, over, I don't want to say obese, but that we are a bit on the bigger size, that it's a risk factor when it comes to giving birth, that it can give you issues. Is that possible?
Rarely.
But that's good to know.
It's rarely. But because, but if you are an active person, So remember, the expected weight gain during pregnancy is somewhere between 12 and if we push it 15 kilos. More than that, we consider that to be weight.
So if you're 80, max go to 92.
We tell you go to 92. Go to 95, we are saying you're African, we'll cut you some slack, not 3 extra kilos. But beyond that, you're putting your own health at risk as a patient.
Right.
There's the belief that if I eat more, I'll get a bigger baby. Babies are born genetically sized.
Do people prefer bigger babies?
I don't know why they prefer bigger babies, because they're more difficult to be born, to give birth to. So
that's interesting.
Yes. So if you have a healthy diet, then you'll not gain as much weight. The more weight you gain, remember also the more immobile you become. The more immobile you are, the more, your baby doesn't have that room to play as much and become cephalic.
Okay.
If I meet a mother who has a particular complication, I put her on bed rest, there's a higher chance her baby will present in a different position than cephalic position, than the one who is actually actively getting out of the house and going and walking.
Awesome.
And that's why we encourage exercise when you're pregnant.
All right.
Yes.
Daktari, let's go through them one by one. We show up, we're about to give birth, and most of us are familiar with the term that you've failed to progress. What does it normally mean when we come and we're in labor and we're hoping it's going to be fast and we're out of here and we're not progressing?
So what happens is, that's a term which most patients are like, what do you mean I'm not progressing? I'm supposed to have a normal delivery. And we expect that every woman has a normal delivery, but unfortunately that's not the case. So what happens is we expect, now the old books taught us that labor should progress at 1 centimeter per hour, and we are more keen in counting from 4 centimeters.
Wait, so that means we are then supposed to be in labor minimum for 10 hours?
I'll tell you about it. So things have changed. So we use what is called a patograph. So when you come, I say I saw you at 2 p.m. and you're 4 centimeters. Then there's a paper called a patograph that we chart the progress of your labor. Labor is divided into 2. You have latent phase of labor and active phase of labor. And it will depend on whether this is your first pregnancy, whether you've had other babies before. So latent phase of labor is from 0 to 4 centimeters. But it keeps changing. Right now, some studies are saying 6 centimeters. Other studies are saying we remain at 4 centimeters. The thing about labor is let the mother labor as safely as possible for as long as possible to have a natural birth, as long as the baby is safe and the baby doesn't go into distress. So if you actually strictly stick to using the patograph, a lot of women would end up with cesarean sections.
Wow.
So there is room to push a mother as long as you're monitoring the baby and the baby is fine, the heartbeat is fine, then you really don't have to rush this mother.
I have a question.
Yes.
How can I be empowered as a mom when I'm on that bed and, in my opinion, feeling what I'm feeling in my body, that everything is progressing well, but the nurse is telling me something else? How do you empower me as a patient to say, you know what, I want to wait it out before we rush for example, a CS?
So the most important thing is when you're attending your antenatal clinic, please arm yourself with questions for the doctor. I'm not saying that doctors are not going to answer your questions or ask you questions.
But we shouldn't be afraid to ask.
Do not be afraid to ask your doctor questions. I said I'll never be intimidated by a patient who tells me I Googled, because some people get offended by a patient who Google, and there's nothing wrong. She's not a doctor. She has a right to Google and come and say, I saw this on Google. Can you clarify this for me? And that's what doctors are there to do.
That would be nice.
So ask all the questions you want about labor. Patients would always ask me, Dr. Kakuti, guarantee me a normal delivery. I cannot guarantee a normal delivery. Guarantee me that I'll have normal progress of labor. I cannot guarantee you. So have these questions. Daktari, what can make me end up with a CS? Daktari, what can make me, what would lead to fetal distress? Everybody knows about fetal distress.
Let's hold the thought there. Let's just unpack it. Fetal distress. I know it's one of the common labor complications. What does that mean?
So fetal distress is whereby when the mother is in labor, remember this uterus is contracting and there's a placenta. So when those muscles contract, the placenta is also affected. So what happens? Blood supply is cut off. When you cut off blood supply, not literally cut off, a percentage of it is reduced, the flow in the vessels. If you cut blood supply, you cut oxygen. So the baby is deprive some level of oxygen.
Right. So
Some-
that's dangerous for them.
It is dangerous for them. But there are mechanisms normally physiologically that are normal that allow the baby to recover. So normally the heart rate of the baby goes down during labor, during a contraction. So it goes down, but it shouldn't go down below a certain level. That's why when you come to a hospital, especially high-end private hospitals, we strap you with a monitor here. Because we want to know how is the baby's heart behaving when you get a contraction, especially when they're very strong. And then the baby's heart should recover back to the baseline heart rate.
Right.
So if that rate either doesn't discover or it starts recovering very slowly or it goes, for example, your heart rate is, the baby's heart rate is between, normally is between 160 to 120, but now it's been changed. Medicine keeps changing. We can now say from 180 to 110 is normal. So if the baby's heart rate was at a baseline of 140,
Yeah.
then it goes down to 100, there's something wrong. Or it comes back to 120, but the recovery is very slow. So there are ways of checking that the baby is not getting distressed during contractions.
Okay.
Because, and one of the signs that we get is either the monitor will show you if the waters have been broken, or the other one is the baby. You're told by the doctor, sorry, your baby has pooped. But the baby can poop in the mother's stomach, but is still okay.
Right.
So if you monitor, a lot of patients may be taken for cesarean section. For me, if you have the apparatus to monitor the labor and the baby, you can actually say, well, the baby has pooped, but the heart rate is still okay, the monitoring is still fine. You can push this mother, but you have to be absolutely careful with your monitoring. Because if the baby is deprived of oxygen to a certain degree, then you're looking at brain damage. A baby
Right.
comes out and the mother is asking, why is my baby not crying? Baby ends up in ICU. Or if they drink them,
Also,
they
those are
breathe
the
in
dangers of
meconium.
fetal distress,
Exactly. Detrimental lifelong calamities.
including
Yeah.
cerebral palsy.
So cerebral palsy is, so people have debated, does cerebral palsy happen during labor or is it a process that occurs when
During-
you're pregnant
Yeah.
that labor exacerbates it? So a lot of research has proven that cerebral palsy is not directly related to labor. The baby already might have had challenges in utero during the antenatal period, but then the stress of labor exacerbates the brain damage.
Okay.
Yes.
Okay. Before we go on a break, if you can touch on any other complication, the one that comes to mind is the one where the baby's shoulders are a bit broad.
Yes.
What is it called? What's the professional term, medical term for that?
Shoulder dystocia. Shoulder dystocia, I think, to me or to any gynecologist is, I think, any gynecologist's worst nightmare.
Oh.
Because, and this is more common with mothers who have with mothers who got diabetes in pregnancy. So the pathophysiology of pregnancy when they have diabetes is that the fat in the baby is deposited in the shoulders. So the condition is called shoulder dystocia. So what happens is when a mother has diabetes in pregnancy, the pathophysiology makes the baby's shoulders deposit
Okay.
with fat.
Okay.
And what happens is a normal size head is born out of the vagina, then the shoulders get stuck. That is a nightmare.
That must be
That is
painful.
a nightmare. And now you have to do certain maneuvers to remove that shoulder.
And at this time, the head is already out.
The heart is. So what happens is the baby's head gets out. The first thing the baby does is what? Start breathing. But the chest is still in the vagina, so there's no room for that chest to expand. And you see a baby turning blue for you.
Oh my
So there are certain
gosh.
maneuvers that we have been taught, and we keep renalling them on how to whatever. Worst case scenario, I think, in my profession was having to break this bone called the clavicle. Because when you break the clavicle, then the shoulder will collapse and you deliver the mother. Other times you have to turn the mother on her force and then deliver the baby the way you deliver an animal.
Yeah.
Yes. So you have to talk to the mother. This has to happen. And the first thing where you taught is shout for help, because you need a team to come and deliver that baby.
I have a question. That means you have to break that shoulder physically with
Not
your
always.
hands.
So there are different maneuvers you have to do. So remember, the problem is not that the mother's vagina is not opening enough. This is a problem whereby the baby's head is stuck behind this bone.
And the shoulders are
shoulder,
broad.
And the shoulders are broad. And they're stuck. So you can't force it out, otherwise you're going to break the bone. And there's a complication if you don't handle it properly. It's called Erb's palsy, whereby if you mishandle that baby, then you paralyze this nerve and the baby's hand forever is going to be like this. Baby can't flex, can't do anything. So you have to have a team that is very knowledgeable, and there are courses we keep taking over and over as gynecologists to renew our knowledge in emergency care. Because shoulder dystocia, breech is another one, which is if you do not know how to manage a breech, you will lose that baby. So you have to be very quick, have a team that is agile and a team that's ready.
Dr. Harry,
Yeah.
let's hold the thought. We take a break and then we'll continue when we come back.
Awesome.
Our conversation today is with Dr. Kakuti. We are talking about labor complications. So far, we've talked about prolonged labor, we've talked about fetal distress, and then our last one was shoulder dystocia. We are going to take a short break and we'll be back right after this. Welcome back to this episode of Today's Parent, where we are having a conversation with Dr. Kakuti on labor complications. Daktari, before we went on the break, there are a few things you also wanted to share on prolonged labor, because I know it's a concern for a lot of moms-to-be and just moms of what to expect during labor and what would cause prolonged labor.
So when you're talking about when a mother comes in labor, discuss the 4 Ps. So the 4 Ps, labor is determined by the size of the passenger, the size of the passage, and then the power of the contractions, and then the psych. Because when you're in second stage of labor, push the baby, I'll tell you, Mom, I need your psych. So passenger is the baby. Remember, this is a bone negotiating versus a bone.
Yes.
Then you have the passage, that is the pelvis, and then the power of the contractions. So if a mother has poor progress of labor, let me go back a little bit, is labor is expected, long time ago we believed was to progress at 1 centimeter to 1.5 centimeters per hour. But if we followed that, then I said earlier that a lot of women will end up with the cesarean section. Because you're just going to say, she's past the action line, because there are 2 lines you have to look at, and then say, oh, she's going to go for CS. So we've said, again, if a mother is progressing slowly but the baby is safe, that is okay. So if you have a very big baby, you can have either a big baby with a mother who has a normal sized pelvis, or you have a normal sized baby with a small sized pelvis.
Yes.
So in most cases, if you have poor progress of labor, if I have no control over the passage nor the passenger, but I have control over the power. So the famous drip that women dread called syntocinon, we are going to give it to you.
I've never heard of that one.
Oxytocin.
Oh.
The famous drip, the one you hear.
And it's a hormone we have.
It's a hormone you have.
Why do we need more?
So if your contractions are not adequate. So when you're plotting the pattograph, we also expect that with certain progression of labor, the contractions should be getting stronger, meaning, now we count the number of seconds you have a contraction. So if you are getting them at 1 contraction every 10 minutes, for 10 seconds, and we say that's early phase of labor. So the strength will be the duration of the contraction, and you see the nurse putting her hand on you or the doctor. Then she'll tell you, oh, they're 40 seconds, those are very strong. And hardly will they go beyond 40 seconds unless now you're going towards second stage of labor. So if we give it the oxytocin, it's because we feel your contractions are not effective enough. And these are things, make sure you're discussing with your doctor, because every woman has heard about the drip. And when I go for baby showers, they say, kuna drip utawekewa utalia. So discuss with doctor, I've heard about this drip, please tell me more about it. And then I'll help you understand why I'm giving you the drip. So that when I give you the drip when you're in labor, it's not going to be a back and forth that, I'm scared of this, and we encourage you to understand why it's important. Because we have to do everything possible to push you for a normal delivery, and a CS should be done unless it's absolutely necessary. As a last resort. But of course, without putting the mother and the baby at any danger.
Dr. Kakuti, I just need you to clarify if there's a difference between the drip that you have mentioned and an epidural.
So there is a difference. So when a mother goes into labor, inherently we actually produce oxytocin from the brain, from the posterior pituitary gland, that actually gives you contractions. But the contractions may not be effective enough to push the baby down. So as the baby needs to be pushed down from contractions, and they kind of vibrate like, to push the baby down like this. But they may not be effective, and so we give you a drip called oxytocin, and there are different names. In the US, they call it Pitocin, syntocinon, that will make us give you better contractions. Or just not better, but coordinate them. So most women will say, oh my God, they're very painful, and talk about the famous dreaded drip. An epidural, on the other hand, is whereby you give an injection of some type of anesthesia to the back, to the epidural space in the spinal cord, to sort of numb the pain that a woman would experience during labor. So unlike a woman who doesn't have epidural, if she's in labor, she's there, she feels the pain. Epidural, she can be scrolling on her Facebook and she's feeling absolutely nothing.
It's like a designer kind of birthing.
It's like a designer type of birth, I tell you.
Wow.
Yes, but it's very common in Nairobi. Yeah.
Interesting. So let's continue talking about the different complications. Perinatal asphyxia. Have you mentioned that one? No.
Yes,
We have?
We
That's the
briefly,
same as...
just briefly. So when a baby has, it's called, normally the term we use is birth asphyxia,
Okay.
not perinatal. But yes, it can be used concurrently. It can be
Right.
used, but I guess commonly what uses is birth asphyxia. So when a baby has fetal distress or there's any compromise to the oxygen supply that goes to the baby,
So it's related to...
birth. It is related to
Right.
birth. So you're right, perinatal during the time of delivery, but we call it intrapartum.
Okay.
Also. So intrapartum is the period during birth. Antepartum before, postpartum after birth. But intrapartum, that time during labor, is called intrapartum.
Right.
So if a baby during labor or even antepartum has any issue with oxygen supply, and of course the brain is the most critical part we are concerned about, then the baby will be born with birth asphyxia. So either they are born and they don't cry. And when a baby is born, they are scored. So we score their color, we score their breathing, we score the heart rate, we score whether they are able to, push around like that. And there's a score out of 10 they're given by the pediatrician.
Right.
So the obstetrician hardly gives a score because I'm the one now, I'm still with the mom. So the baby is born, the baby is assessed after 1 minute, 5 minutes, and 10 minutes and given a score. So babies who are born, maybe they don't cry immediately, and especially the score at 5 is very important to know that the baby may have, permanent damage or not. Most babies, you score them, even if you give a baby a score of maybe even 4, which is low at 1, but they may pick up to 7, 8,
That's a good one.
5, and that's a good baby. They just start crying because sometimes at 1 they come out and they're just tired. We've seen babies who come out and they are just like
oh my gosh,
you people. And
I've been in there forever.
Yes,
and this has taken forever to come
Yes,
out.
and then the contractions, and especially second stage, the mother is pushing that
Must
baby
be stressful
out.
also to the baby.
It is stressful to the baby.
Must be.
There's always some stress to the baby.
This makes us understand. You've mentioned about the pediatrician because sometimes, you're thinking, I'm that kind of ninja mom. Why do I already have the doctor in the room? What is the pediatrician for? So this gives us a good understanding the role of the pediatrician in receiving the baby.
Yes. So it doesn't happen in all facilities. So, but in most high-end hospitals, you have an obstetrician, you have a nursing team, and you have a pediatrician. Depending on the type of pregnancy the mother has, you may actually require a neonatologist. That's a specialized pediatrician. So they deal with babies who are born with a problem.
Wow.
But pediatrician, they're all still trained, but one is more specialized. But sometimes a pediatrician can still do what a neonatologist can do. They're trained. They know these things.
Okay.
And then also doctors and nurses. So even me, I can deliver a baby. If I find myself alone with a patient with a nurse, I may be forced to actually help that baby breathe if the baby comes out crying. So all of us are trained on what is called neonatal resuscitation. So if a baby doesn't cry, then I need to know how am I going to give the breaths, how am I going to resuscitate the baby. But the purpose of the pediatrician makes your work a little bit easier because they are more specialized than what you do. I mean, the last time I treated a baby was in 2006. But we have to be taught these things. So the pediatrician is one who receives the baby, scores the baby, wipes the baby, introduces the baby to the mother. In fact, we hardly introduce the baby to the mother. Mine is tell the mother, your baby has been born.
Right.
They show the baby. I show the baby I'll ask the mother, do you know the sex of the baby? Once I cut the cord, I hand over the baby to the pediatrician. So that now becomes that becomes their patient and no longer my patient.
All right.
But the mother and the baby are my patient as long as the baby is inside there and during birth.
Dr. Harry, before we run out of time, there's one I'd really want you to cover, placenta previa. What is that?
So placenta previa is a condition whereby the placenta is not positioned where it's supposed to be and it's in the lower part of the uterus. So the uterus has 2 parts. You have the lower segment and the upper segment. And the upper segment is actually the main kawaida uterus. So remember the uterus, a non-pregnant uterus is the size of the palm, even smaller.
Can you believe it?
Yes, non-pregnant. And then it grows to gain about 1 kilo to accommodate a 3-point-something, 4-point-something kilo baby.
Sounds like magic.
And it has 2 parts. So you have the upper part, the body, and the lower part, the cervix. So the cervix is what forms the lower segment of the uterus during labor, and then it's taken up. Now, placenta previa is whereby you have the placenta, instead of being attached to the fundus, that is the top of the uterus, it's lower down. And there are 4 grades. So grade 1, it has touched the lower segment. Grade 2, it's in the lower segment but has not reached the cervix. Grade 3 has partially covered the cervix. Grade 4 fully covered the cervix.
Okay.
So if you have grade 2B, grade 3 and 4, guarantee you're going to have a cesarean section because there is no way a placenta can be delivered before a baby.
As you're winding up, it's a question that has come from Emma. I know you had mentioned it before. Maybe a lot more moms, a lot of the other moms also want just to hear you say it again. Her question is, can you guarantee a natural birth? It's like it's the one thing that women are hoping for, but So there's no way.
There is absolutely no way. I have had a patient, I remember she has 9 children. All the 9 children were normal delivery until the 10th one.
Wow.
So it took us 6 hours to negotiate a cesarean section because she was like, I've had 9 normal deliveries.
So what are you telling
but
me
number
today?
10 happened to be 4.8 kilos.
That's a big
And
baby.
all her other babies, none of them was above 3.7. So she fought with us and saying, no, no, no. Until she later on realized, I mean, I've been here for 10 hours, I'm not giving birth. These doctors must be right. So there's no woman you can guarantee neither a pregnancy even within one woman.
So there's no way.
Yes. So you just tell her our hope. And I always say psych your patient up for normal delivery. Psych her up. Like I tell patients, do yoga, do Pilates, do squats. And then, there's the big ball, bite that ball. And there are many things on YouTube you can learn on how to help you have a normal delivery. Be very agile. Don't be a couch potato. Especially those last months. Don't be there, Aki, no, I'm so heavy, I can't get out of that house and move. Tell your husband, baby, let's go take a walk.
Go for a
I tell
walk.
husbands, make sure you come from work. 30 minutes is enough. Just give her a walk because there are ligaments that hold these two. So the pelvic girdle has 3 bones, but they're held into 2.
Right.
And they have ligaments. You want them to start kind of
Do
being
not.
stretchy and relaxy. So when the baby is pushing down, the baby is not like, you want it to be, what? But we can't guarantee you
I
a normal
hear you,
delivery.
Daktari.
But we can guarantee you a safe delivery and a safe mom. At the end of the day, no woman should bash another woman for how they had their baby.
It's like we get a medal when we have natural births and special
Yes.
trophies.
I've been to baby showers where a mother who had a CS was looked down upon by, and you're told,
That where was Kuma?
well, ukusikia uchungu uelewi. So you can't even talk. And I remember being livid. And my friend was telling me, don't say anything because I was almost going to say something really
Mortified.
bad. And I said, anyone who has a baby, even like the other day there was a post about breastfeeding where one mother was feeding the baby through a tube, another one was feeding the baby through the bottle, another one through the baby through, but it was her milk. Yes. It doesn't matter. It's your baby, it's your milk. Once you leave that hospital, it doesn't matter whether your baby was pulled out by a vacuum,
vacuumed out.
Your baby had a cesarean section, your baby came out normal delivery and slipped out like a frog out of water. When that mother leaves that hospital holding her baby, that's our joy.
Thank you, Daktari, for that positive message.
Thank you.
Thank you so much for your time. Always
you,
a pleasure to have you, Dr. Kakuti.
Thank you, Christine.
On that note, we come to the end of today's episode where we talked about labor complications. If you have any other question for Dr. Kakuti, send us an SMS on 22999, and as always, we'll find a way to cover it in another episode. I have been your host, Christine Kasina, and this has been today's Parent. We've been here in studio at Little Cribs, the home of fun, exciting, durable, and affordable kids furniture. For anything labor-related, go over to www.supermamas.co.ke, where you will find information that is going to empower you to have a good labor and probably one of the best birth processes you'll ever have. And I leave you with this special message, especially if you're about to get your baby, embrace the process. And I wish you a safe delivery. Just enjoy it. And remember to breathe.